So excited. Sorry, got the recording message there. Again, good morning. Pleased to be here with you. Always a highlight for me when I get a chance to meet with the interns of PNHP. My name is Roach. I'm the executive director of the Minnesota Nurses Association. I use the pronouns she, her. And I am not myself a practitioner. I am a 32-year trade unionist in the labor movement across two states here in Minnesota and in California. Got heavily involved in health policy work when I was really in California, just watching more and more of the members of our union, which were classified school employees, so not teachers, but bus drivers and food service workers, secretaries, paraeducators, etc., watching them constantly lose the battle when it comes to getting access to health care through their employer by trying to bargain health insurance benefits. It's really a failed strategy in the labor movement to think that we can negotiate these things because we have a common enemy with the management, quite frankly, and the employer, which is this thing can't be bargained because all it is we're just getting told it's going to cost more, shifting more costs onto patients. And we don't ever get to the why. Why is it costing more? And how do we take that on? Right, both from a business perspective, because I am in management myself in the union, and our staff is unionized at M&A, and so I wear double hats. I represent nurses, quote unquote, against the employer in the bargaining table with the hospitals and the hospital systems, but yet I sit on the side of management as the employer with the staff at M&A. So I get to see both perspectives on this issue, and we do practice our values at the bargaining table and have very good and fully paid health insurance for our employees. So we take care of them and stand by that. We're not just fighting for that for everyone else. So I thought I would start today by just showing a little bit of a PowerPoint. It's really just meant to, as I said, provide a little bit of foundation for our conversation today. And it's really centered a little bit around what M&A is thinking about all the time, ongoing, and working on related to really the organizing around how do we win single payer, whether it's nationally or whether it is in the state of Minnesota. How do we win it? What does the messaging look like? How do we bring more people into the movement that maybe aren't the natural allies, such as the Democratic Socialists of America or Our Revolution? Heavily progressive organizations are pretty much on board with this already. But how do we reach out to communities of color who are so impacted? The disability community. How do we even talk to business owners, to people who maybe have a more conservative frame on many issues, but on this one feel like they're being ripped off like the rest of us are, and that healthcare, maybe it isn't a right. Uh, we would say it is, but again, that's framing messaging for people generally who have a more left-leaning political view. But it is a human necessity, and that talking about it as a human need actually works regardless of a philosophical or a political viewpoint, because everybody needs health care. And if that's the case, how do we make sure everybody gets it? Because it's about a public health issue. We are connected to each other, whether we like it or not. And if we didn't learn anything from this pandemic, we should have learned that. We are all connected when it comes to public health. So give me a moment just to pull up my screen here. And let's see, I'm going to just minimize so that, oops, you all can see the actual, there we go. I think that'll work. Okay, now let's see if I can do this. Okay, so first of all, so we really think about how to be simplistic when we talk about single payer, because people, their eyes glaze over when you get too much into global budgets and and all of that. We want them to think about this as assurance for health care as opposed to insurance towards getting health care because we know that insurance creates barriers to care. Single payer is not a nationalized medicine program. So this isn't socialized medicine that we're talking about here. I'm not going to tell you I necessarily think socialized medicine is some sort of an evil, but that isn't what we're talking about. Our Medicare program currently, as it is structured, is a publicly financed, privately delivered healthcare system. And we're just talking about expanding that to everyone. And by the way, it's working in general. Our Medicare system is, so why not just go ahead and keep building on something that's already working? We want to make sure that choice actually means choice. A lot of times we hear, well, if we go to single payer, I'll lose my choice. Your choice of what? What are you losing a choice of? Which, whether to go with Medica or Blue Cross Blue Shield? I mean, come on, that's not the choice. The choice is about which doctor do I want to see? Which hospital is most convenient for me to go to, especially in rural Minnesota, right, or the rural areas of the country. Those are the choices we should be talking about, not whether or not we're going to which type of plan we're going to buy and whether it's going to be a gold plan or a silver plan or a platinum plan. I mean, that's insanity. People just need to go to the doctor when they are sick and not worry about going bankrupt in the process. We want to make sure that all medically necessary services are covered and that they're free at the point of service, and that's what single payer does. And that is the number one barrier to care is finances, of course. And the minute there have been numerous studies done that show that once you get to about $20-$25 or more for a copay, it will immediately discourage people from taking that first step to go in to hopefully deal with their, the care at the lowest level, preventative care, as opposed to waiting until it becomes so much more severe. We want to finance the system through progressive premiums or taxes, or whatever you want to call it, with no deductibles and copays. The calling them premiums versus taxes isn't really meant to be sneaky. It's just everybody's used to paying premiums for access to health care. So what if you write your check to the, I don't know, the Minnesota Department of Human Services or to the Center for Medicare and Medicaid Services, instead of writing it to, again, Blue Cross Blue Shield or to United Health Group or whatever? What difference does that make, as long as you're getting the health care you need when you need it, and not just when you can afford it, right? That's the key piece to it. And really importantly, particularly within the labor movement, is that there is this question that comes up, well, we're going to put a bunch of people out of work if we move into single payer, because all these people have jobs in the insurance industry. And so all of the bills, whether it's a state bill or whether it is national bills, they all contain what we refer to in the labor movement as a just transition. And so that is to ensure that anybody who would lose a job through this change in our economy, that they would be provided a salary for X amount, I think it's a couple of years, while they are being retrained and giving opportunities at no cost to them to learn new skills to be able to make sure that they are therefore able to re-enter the workforce. And it is really this simple, that every single study that's ever been done on single payer has shown four things to be absolute. It will cover everyone, it'll save money, it improves quality, and of course, the most important thing to nurses, and I'm sure to all of you as well, is it saves lives. There is an author who had written a book, and Strangers in Their Own Land of 2018. And one of the things that he said that I think is kind of interesting and pertinent to our discussion is, a lot of people think it's just about money, right? Well, it is to some degree. As I said, it's a barrier, but there is just profound importance in emotional self-interest. So it isn't just always about the money in and of itself. It's very much about people's personal stories and their interactions with our healthcare system or those of a loved one. So a lot of times, particularly in this country, and well, as humans, we think about what it means to gain versus what it means to lose something. And there's a lot of loss aversion that goes on as we talk about this issue, because people are scared of the unknown. They're saying, well, maybe it's not great right now, but I know for sure I've got something. I'm going to be able to go to the doctor, whatever, get seen. And I'm afraid that whatever you guys are talking about I'm going to lose something that I currently have. And so when we look at gain centric messages, we say things like, well, we could save money for other things if we can save money on our healthcare system by streamlining the payment process. But if we say it a little differently, it might bring a few more people in. So that message might work again in a more progressive frame, or room, because we want to have money for, fixing climate, right? Talk about something connected to our health, making sure that there's affordable housing. We want to do things with that money that is equal to the social determinants of health. So maybe prevent anybody having to go and seek health care, because on the front end, we're taking care of some of the major things that cause illness in the first place. But on the other hand, we could say things like, how about we just stop wasting money in this system? Let's be more productive about how we use our precious dollars and resources. Another one is, we say, you want to see any doctor you want, you're able to do it. What if we said, don't let anyone take away your choice of doctor? Because that's what the insurance companies do, right? We know that. We get a little book every year that tells us who we can and can't see. Are they in network, out of network? All that craziness is nothing but business, theories and methods to really keep their costs down. I was in the hospital for about, I don't know, 30 hours or something last January, and I'm still fighting with them about, they thought I'd had potentially a heart attack and wanted to do an angiogram, right? And so of course, I'm admitted to the hospital. They take me to their lab, the cath lab, to get it done. And now I'm arguing with the insurance company because they're saying, well, I don't know, Alina says that you should have gone to an outpatient to get that done. I'm like, An outpatient? Well, then why did they send me to an outpatient? I mean, how ridiculous. I'm in the hospital. Why wouldn't you just get it done there? And then there's the questions about which, did the anesthesiologist, were they inpatient, or excuse me, in network or out of network? What insanity. Who is going to, in the middle of being told they think you've had a heart attack, be dealing with issues like that? This is the craziness of our system, right? We say, let's live longer and healthier. How about if we just say, don't die younger than you need to? Because if you have access to healthcare, that certainly could be the outcome, right? So just some different ways to think about the messaging as we go forward and think about our different audiences. So it is, the loss aversion is losses generally count double the gains. That's why we have to think about that loss-centric messaging. Milt Friedman, I'm sure you've all know who he is, right? He says, so we're asking the question, why not rely on the free market? Interesting, as the free market, guru, right, that he is, he said, the single most important central fact about a free market is that no exchange takes place unless both parties benefit. Well, that's interesting. Does that happen in a free market healthcare system? I saw one medical intern in California when we did a big rally in Sacramento around single payer, had a sign, and it was one of the most powerful signs I felt I ever saw, with a slogan that said, free market healthcare costs lives. And I think that's exactly right, and why we can't have, it isn't a consumable good. It doesn't work in a marketplace. You don't have supply and demand like you do for cars or a television or a computer, because we're trying to survive. It is our life that's on the line. So they take advantage of that because they know, as an Eli Lilly um, head honcho once said, as long as grandma's on the table, they'll pay anything. And they're not entirely wrong about that, right? Because we want to live. So thinking about it this way, that single payer and Medicare for all actually makes really good use of the market, because we pay in, we get this nice little card, and then that card through the CMS, where it's attached to, pays out. What could be a better use of the marketplace than a simple system like this, where clearly, in this instance, the money follows the choice of the patients. There's no exchange that takes place unless both parties benefit. It actually fits perfectly with the theory that Milt Friedman was talking about. I talked a little bit about, using healthcare as a human right. And so, that's really leaning into the issues around fairness and caring. And I think we can all relate to that. But what about tapping into, instead, once in a while, the loyalty, and that it's a common good? that the American dream is all about loyalty and the common good, and so that healthcare is a common good, and therefore should be available to all of us. So, why single payer? It's simple, it's comprehensive, it doesn't have copays, deductibles, and surprise bills, those fun things that are popping up all over the place these days. It never lets anyone take away your choice, your real choice. It's everything else. Everything else we've tried and continue to try is more expensive and far more wasteful. And we're very proud of our Medicare program. So why not simply build on what we know works? So a couple of ideas that I just wanted to share in relation to some talking points that we've used when we're dealing with, oh, I'm sorry, with workers. So why should workers support single payer? Well, it certainly takes control of healthcare access out of the hands of employers. When you think about what we just went through, and we're not out of it, I know that, the pandemic, but particularly at the beginning and through the first, 12 months, people lost their jobs because we were in the midst of a pandemic, but they also lost their healthcare because they lost their jobs in the middle of a global pandemic. I mean, how incredibly crazy is that? So we shouldn't tie health care access to an employment. That makes no sense, again, for us from the perspective of public health, and that healthcare is a human need. Whether you're working or not, you can get sick or be injured, and you need to access healthcare. And for us in the unions, I mean, we spend an enormous amount of time trying to negotiate this beast. Almost every labor dispute that has happened in the last 20, 30 years has centered around, or at least one of the major issues has been about trying to either maintain health benefits or gain them or not lose them. So this continues to be an incredibly contentious issue between labor and management. Easier to just take it off the table. We would much prefer to really focus on some of our core issues around wages. We've seen serious wage stagnation in this country. That doesn't help the overall economy, because when you go to the bargaining table, and obviously there isn't infinite dollars, so when you're trying to figure out how to spread that money out, you end up sacrificing wages because the insurance went up 22%, and you want to maintain as little out of your own pocket as the worker to be able to have that insurance available to you, so you forego wage increases. This isn't healthy for our economy, and it splits workers, because in many cases not all workers may be accessing healthcare through that particular employer. They may be on a spouse's plan or something of that nature. Then guess what? Then you have the workers fighting with each other, because the one who doesn't use the health care provided by this employer is saying, wait a minute, I got nothing, right? Because I didn't even get a wage increase. You guys got a benefit. This doesn't feel like unity and solidarity. So it's very problematic in trying to bargain this. We've lost defined benefit pensions in this country to, be able to retire with dignity and economic security after dedicating, 30, 40 years of employment. We should get back to being able to provide defined benefit pensions again. We see our younger members struggling for childcare benefits and the cost of childcare. How about we negotiate that instead of having to worry about health insurance, where 30% of that precious dollar doesn't even go to health care, right? It goes to administrative waste and absolutely, absurd CEO benefits. I mean, when the CEO of United Health Group can make $66 million in a year, and who did he heal? The answer is nobody. And as a matter of fact, he prevented people from being able to be healed. So he doesn't get to make 66 million of our precious healthcare dollars. And, I don't know a doctor or a nurse who's making that kind of money. And you all do the healing. So if somebody's going to make it, I'd much rather it be you. And we could improve working conditions. Paid family leave is a major issue for people. That should be something that is just automatic, that folks get paid leave to take care of themselves and their families. We could also, the single payer provides much more comprehensive benefits than almost any insurance plan out there that anybody has through their employer in this day and age, because it covers all family members. A lot of employers are only willing to to cover the employee now. And if you want to cover your family, it's a pretty exorbitant price that you're going to have to pay the difference on in order to do that. There's zero copays and deductibles, that first dollar out of pocket. Again, the choice is there as opposed to being your employer choose your networks, because that's really what they do when they're choosing a health insurance company to provide the benefit. They're deciding which doctors you go to and which ones you don't. Happened to me when I was pregnant with my second child and changed changed insurance carriers, therefore had to switch my option in the middle of a pregnancy. And then of course health, prescription, dental, vision, hearing, long-term care is all covered at least under the national single payer bills. And so why would employers care? Why would this be a benefit for employers to support single payer? I don't think people realize the amount of liability on health that is tied to things like workers' compensation, and even, on the outside for ourselves, automobile insurance and all of those kinds of things. They all have a cost in there for potentially having to pay someone's medical bills. Well, think of how those costs could end up decreasing because now everybody is covered. We don't have to worry about who's going to pay for this or that. That's all taken care of. It's not something that an employer has to worry about. Regardless of where an employee gets injured, they're going to get the health care they need to recover from that injury. It also would eliminate the costs and headaches of having to deal with every year the bureaucracy of trying to figure out healthcare plans and negotiations with various health insurance companies. That is a huge pain, and a lot of administrative cost goes into that for an employer. It also would eliminate the complaints by employees when they get socked with, "Hey, we're going to, shift to another plan, and your copay just went up $15, and your deductible just went from 500 to 1,500, and etc." And then employees' the morale starts to go down because they're worried about those kinds of costs, right? It certainly reduces the incentive to have part-time workers. Many employers have told us they would expand their businesses, they would have full-time employees if only they didn't have on their balance sheet this horrendous cost of trying to provide health insurance, because many of them want to do that. They want their employees to have access to health care. They want to be a benevolent employer, but the cost is too high and it becomes unsustainable for them as a business person. It also ends health-related bankruptcies. I'm sure you all know we're basically the only, industrialized nation in the world that people can actually go bankrupt for getting cancer. That's crazy. That is not okay. M&A has for the last 3 or 4 years purchased medical debt, pennies on the dollar, and then we have tore up the debt and relieved thousands of families' burden of medical debt because we believe that right now under this system, we want them to be able to access the care they need without that hanging over their heads. And it also reduces the cost of providing health benefits for the employers that are now providing the coverage, because not all employers do provide coverage. So that helps those who are kind of, levels the playing field on competition. And if an employer provides employee health, or excuse me, retiree health benefit costs, those can be astronomical, because obviously the older we get, the more healthcare we're going to need. So this would be huge on the balance sheet for the liability around retiree benefit costs. Also, as I said, it eliminates the unfair competition. It increases employee morale. Absenteeism is absolutely reduced, and it produces a healthier workforce. And it would mean it's a controllable cost, just like employers, set aside 7.65% of payroll to pay into Social Security and Medicare right now. Same thing would happen here. They'd get percent of payroll. Boom. That's what they go ahead and schedule themselves for, much more predictable on their balance sheet. And I can tell you, one of the groups, entrepreneurs we hear from more than anyone on this issue happens to be farmers, because it is hard for them to predict with crops and weather and everything that happens with that. And if they could just simply say, this is how much I'm going to have to pay every year as a percent of, either for them as an entrepreneur, it might be gross receipts or sales or something of that nature. That's much easier for them to do their books every year and know that their family is still going to be covered with health care. And they would much prefer that. So really the question becomes, what do we want from our healthcare system? You know, do we want a private for-profit institution diverting money away from keeping us healthy? Or, you know, especially when we consider that the government is already spending a huge portion, about 65 to 68% of an entire health insurance company's revenue is coming from public dollars. They don't even get a majority of their revenue from the commercial market anymore. It's already public money. So why don't we spend it more efficiently and get a better bang for our own buck, right? So we're just simply talking about eliminating the part of our healthcare spending that is not conducted in the public interest for public health and therefore accountable to the public. Those are things that should matter, right? Which type of institution should our healthcare dollars flow through? Should it be through an insurance company that skims money off it, has no institutional mandate to care about or care for everyone? Or should it be routed through a democratic, collectively owned institution that has a mandate to serve our universal needs? And then try thinking less about taxes and trillions of dollars and more about what's actually going on. Really, what should the focus of a healthcare system be? Well, the nurses, and again, I would assume you would agree, needs to be patient care. That's what our focus should be when it comes to healthcare. I'm going to try here now. I'm going to exit here for a second because I want to show you a 4-minute video. And every time I do this, I need to make sure, let me go back to here. I might have to come out of here a second because I just want to make sure that I've got this set up. Darn it. Can I get this? So that I've got the, I'm sorry, I'm going to exit for a minute because I need to make sure that I've got it set up where you're going to be able to hear the sound. Because so many times I forget to put on their sound. Where is it here? Oh, this so irritates me. Every time I think I got this down, I end up being wrong. Maybe it's under it might be here. Speakers. Audio settings. Let me see if I can get this. Auto, I want to make sure that it says sound, share sound. Jess, do you know, or excuse me, Jen, do you know where that is, the share sound?
Yes. So on the up arrow at the bottom where it says share screen, when you open that and choose your tab,
there it is.
Yep,
Yay.
it's at the bottom. Yep.
Okay, let me go back then. Okay, so just let me see if I can find, I've got to just reopen my presentation again. I apologize, everyone. I really am trying to do better in learning all of the ins and outs of this as we live in this crazy Zoom world still for a bit. All right, let me see if I can get this to open up. Oh, first I'm going to do this. I'm going to close this so that we can. Sometimes I have trouble getting links to open and even just to open my darn Google Chrome. I don't know why, but it sometimes gets, okay, hopefully.
Among high-income countries, universal health care is standard, except here in the United States. Why is that? Here's a reason that you may have never heard before. Our failure to pass a national health plan is largely due to America's history of structural racism. In 1945, Democrats were in control of the House, Senate, and the executive, and President Harry Truman decided to push for national health care. That year, 64% of Americans supported a national health insurance plan. Support in the states' rights South, which was heavily Democratic at the time, was even higher than the national average. Seem too good to be true? That's because Truman's proposal would have expanded health coverage through Social Security, which at the time explicitly excluded agricultural and domestic workers. That meant 60% of Black men and 80% of Black women were not eligible for the benefit. However, the push for national health care coincided at a time when challenges to Jim Crow and discriminatory provisions in federal programs like Social Security were also underway. In 1946, Truman established a Civil Rights Committee, which desegregated the military and banned discriminatory hiring practices in the federal government. Southern elites began to link new proposals coming out of Washington with threats to segregation in education, healthcare, and housing. The possibility that a national health plan would desegregate the healthcare system and institute a significant transfer of wealth from whites to blacks caused Southern support to plummet from 66% in 1945 to only 22% 4 years later. Southern elites were a core constituent of the Democratic Party at the time, and nothing could be passed without them. In 1949, around the time every other wealthy country was moving towards universal health care, the Democratic coalition fractured and Truman's plan in Congress died. In 1964, the NAACP won a landmark Supreme Court case requiring hospitals built with federal funds, which was most of them, to desegregate. A few months later, the Civil Rights Act was passed, reinforcing this mandate. Passage of a true national health plan was still blocked by Southern Democrats in the 60s, since after the Civil Rights Act, this would have meant desegregating the entire healthcare system. So in 1965, the Southern delegation finally came to the table to negotiate the creation of two groundbreaking, yet limited healthcare programs: Medicare, which initially covered only seniors, and Medicaid, a state-run program for certain groups of low-income people. The Dixiecrats ensured that these programs were designed as much as possible around the racial hierarchies in the healthcare system. For example, Medicare is split into two parts. Part A, the part that covers hospital care, requires no premium. Medicare Part B, the part that covers physician care outside of a hospital, does require a premium. Why split Medicare into two parts? Part B was designed this way so that physicians' offices in the South could claim that it was a voluntary insurance program, not a direct government payment, and continued to racially segregate their offices and refuse black patients. And why was Medicaid created as a federally funded but state-administered plan, while Medicare was administered by the federal government? This compromise allowed Southern states to discriminate against low-income people of color in terms of eligibility as well as benefit levels, and this also dramatically slowed the desegregation of nursing homes. While Jim Crow laws no longer exist, the impact of structural racism on our country's healthcare system has been profound. People of color are still overrepresented in states that have poor safety nets and strict Medicaid eligibility requirements, and new waves of immigrants, particularly Latinx, have fallen into these systems of racial inequity created for African Americans. True national health care, like Medicare for All, was blocked by segregationists during the post-war period when the rest of the developed world was establishing healthcare as a right. By the 1970s and 80s, a large healthcare industry and lobby had emerged, making passage of national healthcare more difficult and likely requiring a massive social movement. It's time to atone for this ugly chapter in our history by building that movement and guaranteeing everyone healthcare from cradle to grave.
So you can see from that how important, oops, I'm sorry, it's started again, my apologies. So you can see from that how incredibly important it is that we address this issue of structural and systemic racism within our healthcare system, within all of our systems, right, in this country. But as we think about how we bring more and more people into the movement to really talk about these issues and be honest about them, and obviously, you know, Medicare for All in and of itself isn't going to fix racism, but it certainly is going to begin to provide an opportunity for access to care that is, again, much more fair, much more equitable, because it's just about being human and needing access and getting that care when you need it. So let me flip back here so I can finish up with the slides. So a couple of real basic, again, messaging tips. Life stories matter. Think of, I'm sure you've heard of Nicole Smith Holt, the Minnesota mother who lost her son at age 27. He died because he couldn't afford his insulin. He had just gone off of his parents' plan under the ACA at age 26, and the started a new job, and the insurance hadn't kicked in yet, and it was $1,300 for him to be able to get his insulin for that he needed for the month, and he didn't have that because he was paying rent, so he was rationing, and he died because of it. No 27-year-old should die in this country of diabetes. And when Nicole, now as a real mama bear, going out there and fighting to make sure that doesn't happen to anybody else, to suffer that kind of a loss, that's a real life story that has made significant change. As now in Minnesota, we have the Alex Smith Emergency Insulin Act to make sure that if people need insulin in emergency situations like Alex's, that they will get it. So real life stories matter, and they move policy. Start with, again, what we get, not be scared about what is the loss is going to be. Making it clear that no one should go bankrupt just to save their lives. It's not a scary new system. It's a system we have that works, and everyone everywhere caring for one another, because public health connects us, really does make a difference for all of us. So these are just a couple of questions that we ask and think about when we're evaluating healthcare reform proposals, because Lord knows there's enough of them that come across with public options and expansions of this and that. So some of the things we think about, particularly the first couple of questions here, are from the Labor Campaign for Single Payer. And that is a campaign working within the labor movement to get more and more unions to be willing to fight for single payer health care. And I'm on their steering committee, and we ask the questions: does it strengthen the social insurance model? Does it help to decommodify healthcare? Does it move us closer to Medicare for all? Does it help us build power and bring in new allies? And does it help to weaken and divide the medical industrial complex and their allies? And this is a good place to tell you that in regards to what Jen mentioned when we first started here, there is right now a proposal as the Senate and the House are negotiating this American Families Plan, President Biden's plan, that they're putting forward a proposal to be able to negotiate for prescription drugs in the Medicare program, because I think you probably know it's illegal to do that right now because the big pharma lobby is very, very powerful. And in 2003, in the middle of the night, they managed to get into the Part D prescription drug expansion of Medicare, the fact that it would be illegal for Medicare to negotiate drug prices with insurance companies for bulk purchasing of meds. If we can do that, if we manage to go into a negotiation process, the Congressional Budget Office is projecting we would save $278 billion a year. And we want to be able to capture that money to do a couple of things, which is to improve Medicare, which is to means it should cover vision, hearing, and dental, because I believe, again, I'm not a practitioner, but I think those things relate to our health, and they should be covered by healthcare, and also to cap how much out-of-pocket seniors and those who are disabled under Medicare would need to put out of their own pocket in order to pay costs. Because right now it's an 80-20 plan, and they have to buy gap insurance, and it becomes really difficult sometimes for people to be able to even use the Medicare program as it's currently structured. So cap costs out of pocket, add expand some of the benefits, improve the benefits, excuse me, and drop the age to 60. So many people stay working between 60 and 65, particularly in industries that are tough on their bodies, because they have to wait until Medicare to be able to have access to health insurance, because it's so expensive in the private market, particularly between the age of 60 and 65. So this would be a huge move in the right direction as it sets up the infrastructure for us to move to Medicare for all eventually. So we absolutely, the nurses, support this, and we're doing everything we can. And please take a moment to call in to Senator Tina Smith, who said she supports this. Thank her for that, and ask her to be more vocal about it and to lobby her fellow senators to support it. Senator Klobuchar has not said that she supports this, so calls into her office we're asking for as well, to say this would be a good thing for the economy, and it would be a good thing for the health of our nation. The other things we ask is, does it cover everyone with no exceptions? So this means nobody gets to bring up, well, I don't know, the undocumented are going to get, health care. Yep, they are. And that's the right and humane and moral thing to do. And once again, it is, by the way, the most economically sensible thing to do. And it relates to the public health. Everybody, no exception, should get access to care. Does the plan cover every medical need without, first dollar out of pocket? Does it lower healthcare costs? Because a lot of times they'll say, well, see, we just provided health insurance companies reinsurance money, more public dollars, so that we can help them pay for the most expensive patients. How did that lower healthcare costs? It didn't. A great health economics professor who passed away a few years ago, Uwe Reinhardt out of Princeton, once said, it's the price is stupid. And it is. I mean, it is, what is the price of that surgery, of that treatment or whatever? Because I'm telling you, you'll find out we don't have a price, or they make the price up just because they can. And then the price is different if you have Blue Cross versus if you have, Medica versus if you have Medicare versus if you're a Medicaid. It's insanity. What's the price? And nobody is trying to say that you all shouldn't make way fair wages. Obviously, we fight for that because you're actually providing healthcare. So it isn't about what you're being paid. It's about all the nonsense in between where it gets wasted and doesn't ever go to actual care, right? Let's talk about actual healthcare costs. Does the plan allow patients to get care from whatever professional clinic that they want to? And does it allow patients and their medical professional to make decisions about the care, not an insurance company agent who's sitting 900 miles away in some, cubicle that's making that decision? The nurses are starting to use a lot on the job in the hospitals, as well as in the labor movement, something we call SBAR. It stands for Situation, Background, Assessment, and Recommendation. So thinking about that in relation to the campaign to win single payer, the situation is we need to pass these bills and implement them. We've got to build support by putting pressure on state representatives, obviously, and senators, especially Democrats. And the reason we say that is because there are many Democrats who will say verbally that oh yeah, sure, yep, this is what we should do. But when it comes down to the hardcore, get your name on a bill, or how are you going to help us move it? How are you talking about it? How are you building the movement? Then they're silent on it. We need the bills to get fair hearings in front of key legislative and congressional committees, and corruption of our democracy and democratic process is due to the unlimited flow of money within the system, things like Citizens United. So this is, of course, a real hurdle for us, and we know that, and it's part of the situation that we're in right now. What's the background? People are suffering. They're dying, literally dying in this healthcare system just because they don't have the money to access it. And we know what we need to be done to create what needs to be done to create a true healthcare justice, excuse me, in this country. And we need to engage more people to make it happen. So the assessment is the polling demonstrates there's a lot of strong support for this system. The pandemic exposed the failures. There's a huge but relatively untapped capacity in the grassroots. They are ready to be called to service. They want to do something. We just have to go ahead and figure out what the ask is and bring them into to participate. I'm sorry, excuse me. And, of course, we are experiencing an historical moment that we have to capitalize on right now. The last time we had this chance was after World War II, when everybody else around the world, for the most part, was instituting some kind of a national healthcare system, and we didn't do it. We can't let this opportunity out of a crisis pass, which of course is the global pandemic. So recommendations. One of the things related to the issue of money and politics and corruption is we wanted our National Nurses United, which is our national affiliated union that we're part of. They are putting on a campaign to put patients over profits and to get candidates and politicians to sign a pledge saying basically that they're going to reject campaign contributions from executive lobbyists and from the PACs that are affiliated with hospital insurance and pharma corporations, all of who are in this really major corporate front group called Partnership of America's Healthcare Future, which sounds so good. They want the status quo and then some. So we really want to try to encourage, our candidates and politicians to seek or to stop seeking or accepting those types of contributions. And then we've got to create organizing opportunities, right? We got to invite our neighbors and our friends to come on over to our house, have somebody from HCAM, from PNHP, from M&A, come in and to have these kinds of one-on-one conversations with individuals, find out how they're feeling about their healthcare system, or our healthcare system, and what we could do to make it better. And then, of course, work to get them to volunteer, to call, to email, to really put on the pressure to our elected representatives to support the bills that are already there, for this system to be implemented. Let's have bigger events. Let's have healthcare town halls. Let's have healthcare forums all over. We're going to do one tomorrow night. M&A is sponsoring one, actually, and to talk about this Medicare expansion and improvement of the American Families Plan proposal. We need to just start talking about this more and more and keep it front and center. And, we've got to recruit volunteers and be volunteers ourselves. We're at some point going to make this into a real campaign. It seems like we only campaign around candidates. Let's campaign around an issue. Let's go door to door and talk to our neighbors and talk to voters about what's going on with healthcare in their lives and whether or not they would be interested in joining the movement and supporting the cause to get a just healthcare system. So it's really easy. We want to pass, as far as what the defined goal is, pass and implement the Minnesota Health Plan, for instance, and when we're thinking about this as being a state campaign at the moment. So, some of the strategies and tactics, we want to increase the grassroots movement is the strategy and get volunteers. The tactic is to relationship build with our ally organizations, to do those town halls and forums, canvas neighborhoods, phone bank, text banks. We should raise a public relations campaign. We should fundraise for billboards, social media ads, create opportunities of earned media. Maybe we should throw some pickets up outside of the Blue Cross Blue Shield, complex over there. I don't know, what is it, in Egan or wherever it is. We also need to elect pro Minnesota Health Plan candidates to the legislature. So we should be attending the campaign events, make sure we ask the question if they're, willing to support it, make the case for why we need it. And then, of course, for those that say that this is absolutely what we need to do, then we should support those candidates and we should help them win. Because someone once said strategy is winning the war and tactics are winning the battle. I do want to say that we can walk and chew gum at the same time. We don't have to fight for just national or just state. We can do both. There's actually a bill in Congress right now sponsored by Roach, representative out of California, called the State-Based Universal Healthcare Act. What this would do is ensure that any state that wants to move to single payer would be able to do so with automatic waivers and no blocking from the federal government. It would take all the money we receive in the state for healthcare dollars from the federal government and immediately put it towards our statewide healthcare system. And it would be wonderful to just not have to seek those waivers, which we can do now, but it would just be automatic. It'd be nicer to just have it automatic. So we support the State-Based Universal Healthcare Act as well. And then I mentioned here again the Medicare expansion. Nancy Pelosi has said she's all for negotiating drug prices in Medicare, but she wants to take that $278 billion and use it to shore up the ACA. But that just, in our estimation, deepens the hold of private insurance in our healthcare system. And it really, we need to refer to those questions again. Shouldn't we use $278 billion that we're saving of our Medicare dollars for Medicare? I think that makes much more sense. So it comes down to this: who are you going to believe? Who really cares if you get sick? Is it the pinstripe suits or is it the scrubs? I'm going to go with the scrubs every time, and the white coats, because they're providing patient care, and that's what they're centered on, and that's what our healthcare system should be centered on. So at the end, bottom line is you can't cross a chasm in small steps. We have to stop with all of this tinkering around the edges. It's time to be bold. We know what the fix is. Let's just do it. So with that, I will close this out, and hopefully that was some food for thought for you all, and we still have some time for some questions if you want. And I don't know if anybody is, Jen, are you sort of facilitating or?
Sure, that was amazing, Rose. Thank you so much. Would you be willing to share your PowerPoint with us?
Of course, I'll send it to you right after this so you can provide it.
Great. I will do that. So I'll send that out to everybody and also put it on our intern page as well. Yes, if anybody has any questions for Rose about anything she presented or any general questions, she is a fantastic resource. She is the lady with the answers. So please feel free to either use your raise hand function or just jump in.
Yeah, it's
Rose,
small enough. Yeah, go ahead, Nick.
I've got a quick question. So I think one thing you mentioned that was really explains a lot was like the money in politics, like Citizens United. Has M&A or other organizations been successful in like, I would imagine that like you said, a lot of companies that provide health insurance to their employees would be interested in single payer for all because, like you said, it's like a fixed cost. Has there been any sort of like engagement of any companies that are like on board to kind of advocate for this or donate their resources to this kind of campaign?
Yeah, that's a great question. So we are working with some business organizations. We're working with the Main Street Alliance, which represents mostly more smaller businesses, but smaller businesses are really the backbone of the economy of this country. Smaller business owners are 100% like, we've got to do this. We just can't even survive as a business if we can't figure out how to deal with this issue that's on our balance sheet. We've also got the I always I get them mixed up. There's a couple of different acronyms for them, but there's another independent business owners association that's mostly Twin Cities based that is very, very interested in single payer. We're starting to try to figure out how to reach out because you're right. I think we've got to get a few really big corporations to be on board with this, something like a General Mills or, an Amazon, who's not so great of an employer per se, but obviously very politically powerful. They tried it, right? Remember, what was it, a year and a half ago when Amazon and a couple of the Bezos and his buddies, I don't remember who all it was, geez, I want to say maybe one of the auto industries or whatever, they decided they were going to figure out how to do healthcare and they were going to just provide it directly to their employees. And that it just blew up. They found out that they couldn't do it. They economically under this current system couldn't do what they thought they could do. So I would hope that that would lead them towards, thinking about how this would be so much better for them. But it's interesting where like the chambers of commerce won't support this. And part of the reasoning for that is because it puts an industry out of business. Right. And in their mind, it's like, oh, where does the government stop if they can just suddenly put businesses out of business, right? Private business out of business. Of course, that has happened through the history of our country. We don't have blacksmiths anymore, right? Right, for horses and all of that kind of thing. But it is because things change and we learn and we figure out better ways in which to do things. And there are ways to put people still to work. And we're not saying the companies have to go under. They can, they know how to provide product, and they can certainly provide insurance for, what I want to say, plastic surgery that's more for, because you want to have it, right? As opposed to you need to have it, such as you had a mastectomy or something and you're going to get a breast reconstruction. That's different than just deciding I want to be a double D or some crazy thing, right? So the idea being that there are ways for them to still exist. They can reinvent themselves pretty easily and still exist. But the chambers, are concerned about that. But when you talk to individual smaller chambers of commerce, a lot of them, because they represent the smaller and medium-sized businesses who don't see this as a particular benefit actually on the balance sheets for businesses, they're like, yeah, no, that's not what's going on here. This is really a problem because we can't even compete globally. They say about $1,500 to $2,000 a car is spent on health insurance for the workers. How do we compete with that when we're competing with globally where it's already built in because Japan, Germany, they provide health care to their citizens. It's a right of their citizenry to have access to health care. They do it in different ways than each other. But the bottom line is that's not a cost the company has to factor in. It's already there. It's just part of the gig. So those costs are absorbed, not the way it is here in America. So we have work to do in getting more and more businesses to really be willing to be vocal on this, but we're getting there. There are some that are speaking out on this.
As sort of a follow-up to that, do you know how some of the employers like in the healthcare sphere that we may be working for, or maybe already do work for, like M Health Fairview, for example, where do they fall on this issue?
So hospital systems are a part of the medical industrial complex. You know, we really sort of call out the evilness of health insurance companies because we see them as superfluous, right? They're just absolutely not necessary in a healthcare system. Hospitals are going to be necessary in in a healthcare system, right? What is problematic from that perspective, and nurses could speak to this a lot, is the corporatization of healthcare. So M Health Fairview has become, I'm going to speak freely here. They're just a horrible employer. They are doing everything they can to decrease access to healthcare. I mean, I live in St. Paul. I was born and raised in St. Paul. They have shut down, Bethesda. They have basically shut down St. Joe's. St. Joe's, my God, that was 100 psych beds. Where United and Region can't absorb 100 psych beds. Our psych nurses are like, what now? Where are these people going to access services? And in downtown St. Paul, when you are right next to, Catholic Charities, Dorothy Day Center, and that really, really takes care of a lot of the homeless population that suffer terribly from mental health issues. I mean, we could go on and on about the fact that mental health isn't treated in this country the way it should be and respected as it should be and offered to people. They are doing everything they can to screw with the grids that nurses have for how to staff nurses properly according to acuity needs of patients. They want to take that professional judgment away. I mean, I don't mean to be like a Debbie Downer here, but when you're going to work for one of these systems, you're a worker. You're a hospitalist. They're going to treat you like they do the nurses, like they do the environmental workers, like they do the food service workers, transport workers. It's like, because we hear this from doctors that are calling us and saying maybe we should unionize because we don't have a voice anymore. They're taking away our ability to practice to our best ability based on our knowledge as physicians. And would it be a threat? Yeah, because we would bust up. There'd be no M Health Fairview or Alina or Mayo. They would be not a healthcare system. There would be like Mayo Rochester. That hospital, that specific hospital under single payer would get a budget. Mayo wouldn't get a budget. Mayo Rochester would get a budget based on the needs of its community. It'd be regional health planning that we could do. And then Mayo couldn't close Albert Lee. So now women have to drive 50 miles, in labor to have a baby safely. So it would be all about funding at the hospital level, not at the system level. And so are the systems going to support this?